As you remember, last time we divided finally peritoneal cavity into two compartments, yeah? Into the supracolic part and into the infracolic part. Again, I tell you guys, all these questions is critically important because then finally, of course, if you choose the surgery as your future profession, you achieve your goal, you take the scalpel, for example, or endoscope, doesn't matter, and you start to make your surgical some intervention, you will have the deal with these structures which I described now for you. And sometimes students ask me, okay, let's imagine that now my room, it is the big peritoneal cavity. And you, for example, it is the organs, yeah, which is located inside of it. Now, what we discuss now? We discuss now these spaces which we have or between different organs, or between organs and the walls. And the question is very simple. For example, dear friend, if I will ask you why I do it, why I waste your time, and I spoke about these spaces, why not to start immediately from organs, yeah? Description of them, I don't know, holotopy, syntopy, stratigraphy. Why I spoke about and speak about spaces between organs, spaces between wall and organs, what the practical meaning of this information?
Because of the contents and its relation?
No, it doesn't have content. It doesn't have content. It is empty spaces. The spaces doesn't have any content. For example, imagine that above you, there are the diaphragm, you are the liver, and between you and diaphragm, we have subdiaphragmatical space. It is empty. By the way, this space is potential space. What does it mean? During the inspiration and expiration, size of this space will be changed. Do you understand me? Why it will be changed? Because then you make the exhalation, your diaphragm goes to upwards, and of course the potential space which will be between you due to the tension of the ligaments will be a little bit enlarged. By the way, during the same exhalation, liver will also goes to upwards because by several ligaments, that is suspensory ligaments, it is connected with the diaphragm. But that is not my question. Now, why I study this narrow potential space? Because time to time, you and roof will be touched to each other, and the space will be disappeared. Or, for example, to much more understand, there are pregastric space, which is between your anterior wall of the stomach and anterior abdominal wall. Now, my left hand, that is the stomach. My right hand, it is anterior abdominal wall. And you can see, yeah, that they have space. But, again, then the stomach will be full. Of course, size of the stomach will be changed. And these two structural units will touch to each other. Once again, and I ask now a question for everybody. Why I describe these empty spaces? Now, what the practical meaning?
Because these spaces can be filled with, like, depends on the organ, like the stomach itself, for example.
Can be filled by what?
Like if the stomach is full, it can fill that space. But
and what? Okay, yeah, I know about it. What is the surgical? Do you think that this is so surgically important information? Do you think that without this information I cannot work in the surgery? That's why I waste now my time and speak about these questions. Please. Incision I do in anterior wall. I don't make the incision in the space. Space, it is something empty. How I can cut the empty? Can you cut the air? I don't understand what about you speak. Of course, thank you very much. Single meaning why we describe these spaces, it is possible content of pathological liquids or some volumetric processes. Don't forget about cancers. So we can have liquid accumulation inside of these spaces, or we can have volumetric processes inside of the space. Especially in the immediately here, I will attract your attention into the metastasings. And especially primary, first of all, lymphogenous metastases, yeah? Because as you know, inside of our cavities, we have huge amount of the lymphatical structures, which is drain normally our organs. And of course, they can contain the lymphatic metastasis. As the surgeon, you must find these structures, and if it is necessary, remove them during the surgery into the cancer. That's I remember forever, guys. Two meanings why we describe these species. Number one, liquid pathological processes. Number two, solid pathological processes. Primary, this is the cancer, so the metastasis of the cancer. That's I write, please, in supracollic compartment, except organs, which is located inside of it. There are three spaces. Space number one we call subdiaphragmatical space. Space number two we call subhepatic space. Space number three we call bursa aumentalis. Subdiaphragmatical space, subhepatical space, and bursa aumentalis. Let's first of all imagine all these compartments, yeah? Now, I will attract your attention into this picture. Look, everybody, please, to this picture. What is it? Every time I tell you, guys, I suggest you. Then you open my slides, and then you read some information. Try to find it in the pictures. Look, I don't randomly put the pictures in my slides. I put especially the pictures which show some problems. Now, attract your attention. Primary, I don't know, I don't have the stick to reach it. That's I will show it by my mouse. Primary, attract your attention, please, into this narrow space, which is located immediately below the diaphragm. Diaphragm forms the upper border of your peritoneal cavity. Yeah? As you remember, it is splitted your peritoneal cavity from thoracic cavity. It is the dome-shaped structure. What is located below your diaphragm? Approximately below right 2/3 of your diaphragm, you can see we have totally our liver, which is presented by two lobes, yeah? Biggest one, it is right lobe, approximately 2/3 of the liver mass. And finally, in the left side, we have left lobe. But again, attract your attention in the picture. Can I say that below the diaphragm, I have totally only the liver? No. If you will look to the most left portion of the subdiaphragmatical space, below diaphragm you will see two structures. It will be the stomach and it will be the spleen. That's why once again, if my roof will be the diaphragm, my floor will be presented by three structures. Right 2/3, that is the liver. Then a left portion divided into two places. From right to left, it is the stomach, and finally the most left portion, it is the spleen. That's why this is space number one. We call it subdiaphragmatical space. Little after we will make subdivision of it, and we will describe what is most important, walls of this space. You should know how you can enter into this space, how you can clean this space, how you will drain this space. General, tell me please, what does it mean, the drainage? Once again? Xylem, please. What does it mean, drainage? This is the surgical procedure. By the way, we need attention. In your practical skill questions, you will have the question about the drainage of the wounds. Which kind of surgical manipulation we call drainage? Please, Xylem. What we call the drainage?
To remove the pathological process.
That's for example, there are appendicitis, inflammation of appendix. I remove the appendix. In your opinion, that is called the drainage?
No.
So you say removing of pathological process. I have pathological process in appendix, I remove it, and in your opinion that will be called drainage.
Pathological fluid.
Pathological fluid. Now he is near to the correct answer. Let's say removing of the pathological fluids from internal cavities of the human body, we call the drainage procedure. Can you imagine how I can achieve this manipulation? How I can make it technically? What I need? For example, imagine that in front of you there are the peritoneal cavity with pus. And you should remove this pus. Tell me please, Xeron, what do you need to do it? If you will say pathological process, go away from here, it will go.
No.
So you must do something.
Pumps.
First of all, we can need the pumps, some vacuum machines. That is enough?
No.
What else? Awful. Drainage tubes. Because I can have drainage tubes, I must to have sometimes pump. Why sometimes? Because we can have active drainage and we can have passive drainage. What does it mean passive drainage? Due to the difference of the pressures, usually inside pressure is higher than outside. Let's say just by the gravity forces, if you will insert it, the drainage tube inside of the cavity with high pressure and descend it to down, because liquid pass from up to down, so we can achieve the chance to remove the liquid. If it's not enough for you, as our friend is suggesting, I can use some sucking machines, some pumps, which is make the negative pressure and which is evacuated much more actively the liquids from the species. So remember, please, in case of, it is very important, listen what I say here, in case of any liquid process, you must to make the drainage of the space. Otherwise, it will be spread through the whole compartment of this space and can give possibly mortal complication. By the way, it doesn't matter which kind of liquid is it. It can be pus, it can be blood, it can be serous liquid. Why doesn't matter? Because all these liquids, it is great environment for microorganisms. If there are blood and you don't remove it, hematoma, after several times it will be inflamed and will give the pus. And this pus can be spread through the whole cavity with formation of the peritonitis. Do you understand me? Let's say right, please. Subdiaphragmatic space and its division. Yeah, before speak about it, I forget to show two another spaces. Yeah. Now attract your attention, please, into this space, minute tension. The space which is located below the right lobe of the liver, up to the lesser omentum. You can see that this is previous time I described for you. Yeah, what is the greater omentum, what is the lesser omentum? We spoke about it. Let's say the space which you see we call subhepatical space. As you can see, inferiorly, partly it is stomach, from left to right. Partly it is superior horizontal part of the duodenum, and partly it is the left knee of the transverse colon. Is it visible for you? So imagine now that you inserted your hand just below the right lobe of the liver. By the way, and a gallbladder will be here, which is attached to the inferior surface of your liver, yeah? Let's say this is subhepatical space. And finally, you can say, Mister, where is the third space, which is called bursa aumentalis? To answer in this question, I will open for you the picture which we do together in my previous class. That is the sagittal section of the peritoneal cavity, passage of the peritoneum. Look immediately into the blue sac, which we call small peritoneal sac. Other name of this sac, it is bursa aumentalis. We drew it previously, if you remember, in my class. Yes or no? In my previous lecture.
Yeah, abdominal pelvic.
You didn't? It is first year lecture, yeah? Why you don't remind me? Because previous week I read the lecture for another groups, not for you. So bad persons. I waste so much time until you tell me that that is the first time that we speak about peritoneal cavity. Don't write anything. Picture, please, take from your friends. So I don't have now time to describe it for you. I will start it from the primary points. The peritoneal cavity. Now look here, please. This is one from the 4 compartments of abdomen. As you remember, abdomen has 2 walls and abdomen has 2 cavities. Immediately behind of your anterior abdominal wall, we have peritoneal cavity. Why we call it peritoneal? Answer is simple. Because it's formed between parietal and visceral layers of the peritoneum. What is the peritoneum? Peritoneum, it is serous membrane. Peritoneum has one layer of the serous cells, which is located in basal membrane, and these serous cells have important functions. They can conduct and they can make the absorption of the serous liquid. By the way, experiences show that the visceral peritoneum, which is covered the organs, mainly make production of the liquid. Parietal peritoneum, which has great drain into the intercostal veins, yeah, it is mainly make absorption of the peritoneum. And do you know what is important? I will remind you now for your physiology and histology. Speed of absorption 5 times more than speed of production. And do you know what is the final result of this? No any accumulated liquid. Remember, please, accumulated liquid, it is pathological disorder. By the way, such kind of the liquid we call free liquid. So remember, please, what does it mean free liquid? Physical rule, any liquid, if it is free, descended to down and accumulated in the lowest part of any cavity. If you will now flow the water into the floor, it will find it the lowest place because the less energy is necessary for the accumulation in the lower place. Normally in your peritoneal cavity, we don't have any accumulated liquid. That's why there is this serous liquid in the surfaces. It is lubricated the surfaces and decrease the friction between the structures. No any accumulation. If you will make sonography and will find the free liquid inside of the peritoneal cavity, it will immediately show for you pathological process. Otherwise, other question, which liquid is it? It can be blood, it can be serous liquid, it can be pus, it can be lymph, it can be urine. But anyhow, it is show something pathological. Peritoneum has another functions also. That is immunity function. It is the activation of the macrophages and other phagocytic cells, which is located inside of it. It is the drainage of the liquids, as I said before. Yeah, it is the metabolic activity. It can make the secreting functions as your kidneys. But primary main effect, it is, remember please, it is production of this liquid. By the way, peritoneum also can produce the fibrin and can gives the stitching inside of the peritoneal cavity. What does it mean? If organ, for example, will be perforated, peritoneum can produce the fibrin and try to close this perforational aperture. This is also very important quality because it is preventing formation of the peritonitis. Unfortunately, it doesn't work every time. Because if there are the big aperture and if content of organ come to outside, anyhow it is gives the formation of the peritonitis. 1 minute attention to it. Let's say we understand that peritoneal cavity, it is space between visceral, she is organ, she is covered by peritoneum. I am the wall, I am also covered by peritoneum. My peritoneum called the parietal layer. Her peritoneum called visceral layer. Let's say, look, space which is located between us, between me and Dennis, it is again potential space. Why this space is potential? Because she is movable structure. She can increase the size, she can has the content. Finally, she has peristaltical movements. And we can attach to each other, or vice versa, we can go far from each other. As a space can be enlarged, or space can be decreased. So remember, please, this space, don't sleep, please, listen to me. This space is potential space. By the way, our peritoneums is passed to each other. How it is passed to each other? By ligaments. You know, there are the ligaments which start from me and finish in the organs, or which start from organs and finish in the wall, or which start from one organ and pass to another organ. If ligament, what is the ligament? It is duplications of the peritoneum. Peritoneum can make double layers, as you can see I make now by my white coat, and can share this double layer into the neighboring structures. Usually it has two meanings. Meaning one, number one, it is suspensor ligaments, which is make fixation of the organ in its place. For example, falciform ligament of the liver. You know, in sagittal plane, it is connected the diaphragm with the liver and prevent distending of the organ to die. Or, much more important, I can have nutritional ligament. Nutritional ligament usually, look to me, if I am posterior wall of the peritoneal cavity, I am covered by parietal peritoneum, yeah? Behind of me, we have retroperitoneal space. We study it together. You know, biggest vessels and nerves located in the retroperitoneal space. She is some organ. I will deliver now somehow these vessels and nerves from retroperitoneal space to this organ. How I can do it? By formation of duplication of my peritoneum. And inside of this duplication, we will have vessels and nerves. And through this ligament, they will reach the necessary organ. By the way, after she can share part of these vessels and nerves to another organ. It will be now the ligament which is located between two different organs. There are third type of ligament also, guys, remnant ligaments. You remember the last time, for example, we described a round ligament of the liver. Functionally, it's not so important because it is embryonal structure remnant. Let's say, remember, please, finally, what is the ligament? It is duplication of the peritoneum. What is the function of the ligaments? Or it is make suspending function, or it is make nutritional function, yeah? They provided the vessels and nerves from the whole to organ, or from one organ to another organ. Is it understandable for you? That is more than important. Now, 1 minute attention to me. Histologically, I want to remind you that except division into the parietal and visceral layer, by the way, you see now that this parietal and visceral layer, they traverse to each other in the place of the ligament. Now, if the ligaments start from me and come to her, means parietal peritoneum, become to the organ, change the name and call the visceral. Means histologically they have same structure. Absolutely. But there are one more classification of the peritoneum. As you remember, we described and divided into the dorsal and into the ventral layers. By the way, each one has parietal and has visceral compartments. What does it mean, ventral peritoneum? Ventral peritoneum, that is the part of the peritoneum which is covered the biggest anterior portion of the peritoneal cavity, and walls and the organs inside of it. By the way, in this picture it's shown by the red and by the yellow colors. As you can see, this is the big peritoneal sac, except one blue place. Blue place which is located behind of the stomach and which is called the bursa ommentalis. This blue place covered by dorsal peritoneum. That's it. Again, histologically no big difference between them except one. Ventral peritoneum thrice better innervated than dorsal one. What about this? Do you see the stomach in this picture? This ring which you see, that is the stomach. Now imagine that you have two patients with ulcer of stomach. One patient has ulcer of anterior wall, second patient has ulcer of posterior wall. And both these patients have the complication of ulcer disease. By the way, what is the etiological cause of the stomach ulcer? Mainly, Once again, this is the main cause. It is one of the causes, but not the main, of course. Helicobacter pylori, it is the main etiological cause. Microorganism, yeah, negative micro. Okay. Now we need attention to it. Both these ulcers have complication, which is called perforation. If it is in anterior wall, content of stomach will flow to the big peritoneal sac. If it is in the posterior wall, it will flow to the small peritoneal sac, which is called bursa aumentalis. By the way, immediately attract attention into this aperture. Do you see it? I will show it in the real pictures. 1 minute attention to here. This is the same aperture. This is in frontal plane. That is in sagittal plane. Do you remember how we call it? Epiploic aperture or Winslow aperture. Winslow aperture. Now look, if my room will be big peritoneal sac, my entrance will be small peritoneal sac, my door will be called the lesser omentum, and this small window in the lesser omentum will be called Winslow aperture. But just we must have vice versa picture, yeah? The great peritoneal sac will be right, small peritoneal sac will be a little bit left, yeah, you understand? But this will be the Winslow aperture. Single connection, communication between big and small peritoneal sacs. So remember about it, that is very important. Let's say left side here, yeah, and back side, we will have small peritoneal sacs, right and bigger one, we will have great peritoneal. And single aperture, which we have, which is connect these two sacs to each other, is Winslow aperture. But finally, if the stomach content flow inside of the big sac, red and yellow, huge irritation of the nerves will be happen, because I say you ventral peritoneum has great innervation and it will give the peritoneal signs, awful pain. If content will flow into the blue sac, which is the bursa aumentalis, again peritoneal will be irritated, it will be inflamed, but pain will be not so developed because it doesn't have good innervation. How much? Up to content will come to the Winslow aperture and will be flowing inside of the big sac. Let's say posterior wall perforation is much more dangerous because you lose the time. You don't understand the clinical sign and symptoms. Usually you think that this is the back pain, which is connected with vertebra, until the person will be dead. As I remember, please, this is the difference between dorsal and between the ventral peritoneum. That is more than enough for you. Okay? Now about the passage of peritoneum in the sagittal plane. You can see that in the sagittal plane, look please here. Let's start from, for example, from ligamentum coronarium hepatis. You know, it is the biggest suspensor ligament. And it makes your liver mesoperitoneal. By the way, before I will start to describe for you the passage of peritoneum, let's remember anatomy. Organs covered by peritoneum in 3 different ways. Intra, meso, and extraperitoneal. What does it mean, intraperitoneal? Now look, I completely covered by my white coat. Or white coat cover me completely, but it forms some ligament, yeah, which is provided vessels and nerves. Example number 1, it is your sickle. It is completely covered without any ligaments, like your socks cover your foot. Example number 2, it is the stomach. It has the ligaments along the greater and lesser curvature, which is provided vessels and nerves to the stomach. But anyhow, stomach is intraperitoneal. These narrow belts, which is provided vessels and nerves, it's not enough, yeah, to call it mesoperitoneal. Generally, what does it mean, intra? More than 90% of the organ covered by the peritoneum. What does it mean? And by the way, now hold please on white coat. Of course, you understand that intraperitoneal organ will be movable. And the more will be the length of my ligament, which is connect me with the wall, the more I will be movable. Vice versa. If this ligament will be very short, my movement will be not so big. Thank you very much. Is it understandable for you? By the way, biggest ligaments which is connected posterior wall of organs with the posterior wall of the peritoneal cavity with the organs we call mesenteries. Mesenteries, it is only nutritional ligaments because they provided vessels and nerves from retroperitoneal into the organs. Longest mesentery have your small intestine. This is the middle part of the jejunum and ileum. Remember, this is the most movable structures of the peritoneal cavity because they have the long mesentery. What does it mean, mesoperitoneal structure? Now look to me. I'm the organ which is touched by the back to the posterior wall. And I'm covered by peritoneum from three sides. From in front, right and left. Then peritoneum passing to the posterior wall. Do you see that I am fixed? I cannot be moved. I will be called mesoperitoneal structure. And mesoperitoneal organs is unmovable organs. So remember, please, in peritoneal cavity, you will have, don't sleep. You will have these two types of the organs, intraperitoneal and meso. What is the third type? Extraperitoneal. Sorry, can I say that extraperitoneal organs also located in peritoneal cavity? No. No. Because extraperitoneal, it means it's covered only from one side. It means it is located outside of the peritoneal cavity. In which species, from that point of the view, we can have extraperitoneal organs? If they cover only from one side by peritoneum. Which species can be belong to this specificity? Or, you're right, second species, which can have extraperitoneal organ. You can. Try. You say the space which is behind of peritoneal cavity. Maybe. If will be done. How we will call the space which is below your peritoneum? Pelvis. It's so funny. That's why if it is pelvic organ, it will be covered only from upwards. If it is retroperitoneal organ, it will be covered only from in front. But anyhow, both these cases, it is coverage by one side. So we call it extraperitoneal. That's why don't include it in your controls, please. Extraperitoneal organs into peritoneal cavity. They doesn't locate it in peritoneal cavity. They locate it or behind of peritoneal cavity, means in retroperitoneal space. Great example for you, it is kidney. Kidney is covered only from in front by the peritoneum. That is not the organ of peritoneal cavity. That is the organ of retroperitoneal space. Or for example, your empty urinary bladder. It is covered only from upwards. Sorry, it is not organ of peritoneal cavity. It is the organ of the pelvis. Do you understand it? Let's remember, please. Now 1 minute attention to me. Again, let's look to this picture. Let's look, please, here. From the region of the coronal ligament of the liver, anteriorly you have the ventral peritoneum, posteriorly you have dorsal. Ventral peritoneum covers the diaphragmatical surface of liver up to the inferior margin. Then it is covered inferior surface of liver up to the hilum of the liver. Dorsal one covered the lobus caudatus, posterior surface, and again it is come to the level of the hilum of the liver. Here they forms the ligament, which has two layers. Look, anteriorly ventral, posteriorly dorsal peritoneum, and this ligament come to the lesser curvature of the stomach. Much more better, you can see it in this picture. These ligaments we call hepatogastral and hepatoduodenal ligament. Gastral come to the stomach, duodenal come to the superior horizontal part of the duodenum. These two ligaments together we call lesser omentum. What after, guys? Now look, ventral one covers stomach from anteriorly, dorsal one covers the stomach from posteriorly, and in level of greater omentum, they forms three ligaments. Now look in this picture, all ligaments is visible here. It is the diaphragmatical, gastrasplenic, and gastrocolic ligaments. This is 3 ligaments, which is included in greater omentum. Much more better, greater omentum. You can see this in this picture. Greater omentum descended approximately up to the level of your greater pelvis, upper margin of your greater pelvis. And it is covered from in front all small intestinal loops. Let's say, look what is happened. 2 layers descended to down, anteriorly ventral, posteriorly dorsal. And 2 layers after come to upwards. Let's say your greater omentum has 4 layers. 2 anteriorly, 2 posteriorly. And it's greatly visible that in embryological time of our life, inside of greater omentum, there are cavities. After, guys, during the first 2 years, the layers of greater omentum is fused to each other, and this cavity is loosed. Greater omentum has great function for you. First of all, here we have the storage of the blood. Here we have a lot of the immunity structure. Here we have the storage of the fat. Greater omentum provided immunity reactions. Greater omentum deponizated the blood. Greater omentum has protectional effect in case of inflammations of the intraperitoneal structures. For example, she's intestine, she's inflamed. What is the function of the greater omentum? Greater omentum in this region start to producing the fibrin, and it is glued to this inflamed structure. It is prevented spreading of the inflammation. But now imagine that she is perforated. If I will not be touched to her, this inflammation will be spreaded through the whole peritoneal cavity. We will have formation of the peritonitis. If I will touch to her, again, inflammation will come to the pocket between us, and we will have abscess. Abscess, it is separated, inflammation. It is much more better prognostically than diffuse inflammational problem. Okay, let's become again to the picture. What after? After this, these dorsal and ventral layers cover the transverse colon, and together they form the mesentery of the transverse colon. And due to this mesentery, dorsal layers come to the posterior wall, cover posterior wall, pancreas, you can see, your kidneys, and finally come to the first place of our destination. It is ligamentum coronarium hepatis. Here we will finish. Let's say this dorsal layer from all sides, as you can see, enclose this blue space, which is called bursa ommentalis, or small peritoneal sac. What about ventral layer? Ventral layer come to the posterior wall and descending to down. It gives the coverage for all small intestine, which is covered intraperitoneally. It forms the mesentery of small intestine. Then it is descended to down. In the inferior compartment of the peritoneal cavity, attract please your attention into this picture. For males and for females, it is differently covered the structures. For the males, it is covered the rectum by 3 ways. Upper third, intraperitoneal, middle third, mesoperitoneal, lower third is extraperitoneal. From rectum, it is descended or it is passed into the urinary bladder, and depression is formed here, which we call excavatio rectovesicalis, lowest point of male's peritoneal cavity. In case of pathological liquids, guys, vertical positive, all the liquids will be accumulated here. Then you can see that for the males, from urinary bladder, it is passed to the anterior wall. There are small pockets, which we call here Retzius pocket. And then it is come to the final place of our destination from which we start our description. And again, ligamentum coronarium hepatis. Let's say it is covered all anterior wall, diaphragm, and we enclose the big sac of the peritoneal cavity. What for the females? Little bit another situation, because instead of 2, we have 3 organs. We have the rectum, we have the uterus, we have the urinary bladder. That's why from the rectum, it is passed to the posterior wall of the vagina. It is covered the cervix of the vagina. It is covered all uterus. And then it's come to the anterior surface of the uterus and doesn't reach the level of vagina. From the uterus, it is passed to the urinary bladder, and instead of one, we have formation of two depressions. It is recta-uteral, we call it also Douglas space, and a uterovesical. Recta-uteral space, it is the lowest point of the female's peritoneal cavity. And any free liquid of the female's peritoneal cavity, bleeding, pus, will be accumulated here in Douglas space. How we make usually investigation? Or per vaginal or per anal. Per vaginally, if you touch to the fornix of vagina, you can find two situations: normal fornix or depressed fornix. Depressed fornix show that Douglas is not empty. If Douglas is not empty, liquid is push the fornix and make prolapse of it. Prolapse. Then you touch the wall, instead to see absolutely smooth and straight structure, you see prolapse. What else you can do here? Puncture. From the same fornix, you can make puncture of the Douglas space. You can take the liquid for investigation. Histology, cytology, I don't know. I don't make mistake when I say histology. Because instead of the liquid here, we can have the tumors. And you can make fine needle biopsy. Or if it is still liquid, of course, you will take the specimen for cytological investigation, not histological. And this is understandable for you. Now attract your attention into the radius pocket. And for the males and for the females, that is the passage place, between inferior and anterior wall of the peritoneal cavity. You know, it is very movable. Now imagine that I am the bladder. I am covered from upwards. Then I am raised to up, in which time? Then it is filled by the urine, This radius pocket symmetrically with me goes to upwards. I am covered in filled situation not only from up but from sides, but not from in front. That's why if your urinary bladder is filled, your patient, and you will make puncture of it by upper margin of the pubic symphysis, you will not damage the peritoneum. You will not enter into the peritoneal cavity. Again, why? Because this radius pocket, it is movable. Then the urine is filled, the bladder rises to up, and it is pushed the peritoneum to the upwards. Remember please, bladder doesn't cover by peritoneum from in front. Full bladder covered from up and from sides. It's become to mesoperitoneum, but not to intraperitoneum. Is it understandable for you? Finally, friends, we have the males, we have the females, and let's understand what is the principal difference between males and females peritoneal cavity. I think from anatomy you remember, for the males it is closed sac without any communication. For the females, by the uteral tubes, by the cavity of the uterus and vagina, it has communication with the environment. So remember, please, by the way, that is one of the explanations why anaerobical infections is much more usual for the males. Because no any air, no any oxygen inside of this space. For females, very small but amount of it, by this communication, can reach the peritoneal cavity. So remember please, females peritoneum, it is communicated space. Males peritoneum, it is closed space. Do you understand this? I am so happy. Now once again, look to me. Let's come to these ligaments, and very quickly we will come to the spaces. Ligament, it is duplication of the peritoneum. Ligament can be divided, ligaments, into three groups, as I say you, yeah? Suspensor, nutritional, and remnant ligaments. The most important, of course, it is nutritional, especially from surgical point of the view. Why? Because if you make any surgery into any organ, you must to find its supplement vessels to arrest the bleeding or to ligate for the removing of the structures. And these vessels will be primary inside of the ligaments. Such kind of the ligaments, if they started from posterior wall, we call mesenteries. So remember, please, nutritional ligament, as I say, yeah, in example of me and Dennis, I show you for you, it can come from posterior wall to organ, or from one organ to another organ. If it is come from posterior wall to organ, we call it mesentery. Let's say then you listen this term in mesentery, you must to imagine the ligament, which is start from posterior wall, come to some organ and provide it vascularization and innervation of it. Mesentery have only intraperitoneal structures, because then this ligament reach the organ, it is covered from all the sides. Which organs have the mesenteries? Small intestine, transverse colon, sigmoidal colon, appendix vermiformis, it is also mesenterical structure, stomach in the greater and lesser curvature. That's it. All these organs which I mentioned, it is intraperitoneal organs. And they have nutritional ligaments, guys, which we call mesenteries. Remember, please, the more will be length of mesentery, the more organ will be movable. Vice versa, the shorter will be mesentery, the less movable will be organ. Idea is understandable for you. That's why remember, primary, guys, only intraperitoneal structures have the mesenteries. Second structural unit, it is omentums. What is the omentums, guys? Remember, please, this is the ligaments. Listen me attentively, which is primarily located between different organs, which also have nutritional meaning, that say they contain vessels and nerves, and also they deposited the fat. Inside of the omentums, we have fatty tissue. It is so-called, which kind of fat is it? Oh, where is your anatomy knowledge? Visceral fat. We have two types of the fats, yeah? It is the wall fats, it is subcutaneous fat, deep loose connective tissue fats, and it is visceral fat, which is located inside of the cavities. By the way, not only peritoneal cavity, and inside of thoracic cavity, and inside of the pelvic cavity, we have visceral fat. By the way, we don't have visceral fat inside of the cranial cavity. We don't have. But inside of whole mentioned cavities, yeah, the thoracic cavity, you don't imagine how it is covered, for example, pericardium. We can have huge amount of the accumulated fat. It is covered the organs, it is located inside of the greater omentum, lesser omentum. It is located inside of the pelvis. This fat we call visceral fat. By the way, in early childhood, if you remember, part of this fat presented by brown fat, which has the huge metabolic activity. It is produced 5 times more energy than simple white fat. Is it understandable for you? Super. Where is our mesenteries? Now look here, please. Lesser mesentery located above the lesser curvature of the stomach. Greater mesentery located below the greater curvature, partly out. Lesser omentum generally has 2 big ligaments. It is hepatogastric and hepatoduodenal. Also inside of it we describe hepatophrenic, hepatoesophageal and hepatocolic ligament, but it is very small. Biggest ligaments is 2. Hepatogastric, it is from hilum of the liver to the greater curvature of the stomach. Hepatoduodenal, from same hilum of the liver up to the superior horizontal part of the duodenum. Greater omentum has 3 ligaments, as I say you. Gastrophrenic, gastrosplenic, gastrocolic. And again, I will come to the point from which I start. Spaces. And primarily, I should remember that our transverse color, together with its mesentery, is greatly visible, by the way, in the sagittal section. Do you see the second ring? There's a first ring, it is stomach, below the liver. Below the stomach, you can see transverse column. The tail of this transverse column, which is going to posterior wall, we call mesentery of the transverse column. Now, transverse column with its mesentery splitted your peritoneal cavity into two compartments, supracolic and infracolic. In each compartment, there are two types of the structural units. Type number 1, organs. Type number 2, species. Let's say now we speak about supracolic compartment. Yeah, meaning the tension. Which organs we have inside of it. To answer this question, I will show for you, for example, this picture. Now, you see the transverse column? By the way, which form it has? A loop-shaped form. Knees is located higher than mid part due to the gravity forces because it has long mesentery, middle portion descending to the. That's why, as you remember, knees we projected in superior anterior wall. It is epigastric compartments, yeah, right and left hypochondrial. Middle one in umbilical portion. It is the middle part of the anterior wall. Remember about it. Let's say which organs were. You see liver, you see gallbladder, you see greater omentum, or lesser omentum, you see the stomach, you see the superior horizontal part of the duodenum, you can see the spleen. Unfortunately, it doesn't show, but it is located left to your stomach. Which species we have inside of it? 3 which I mentioned before. It is subdiaphragmatical, subhepatical, and burso-omentalis. Now look in the inferior portion. What we have inferiorly, guys? Primary loops of your 2 parts of intestine. It is large intestine, it is small intestine. Which species we have inside of it? Look to me. You have 2 channels. They located along the ascending and descending intestines. You have 2 sinuses. They located along the root of the mesentery of small intestine. Look, small intestine is removed. This is the root of its mesentery. And these 2 spaces, which is located right and left to it, we call mesenteric sinuses. And so once again, 2 channels, 2 sinuses, and 6 pockets. What does it mean, the pockets? To answer in this question, I will show this picture. That is posterior wall, and in some places, for example, in place of transition between duodenum and jejunum, behind of cecum, behind of sigma, you can see depressions now of posterior wall. Depressions of posterior wall we call pockets. Inside of these pockets, we can have 2 pathological disorders. Disorder 1, accumulation of liquids. Disorder number 2, remember forever, formation of internal hernias. That is something unique. Hold your hands like this. No, like that. This is depression. I am some organ. I can be inclinated inside of this depression and pressed by the muscular units, which is here. Such kind of hernia we call internal hernia. Previously, we described external hernias. You remember, protrusion of organs to outside through the weak places. Now, what is the internal hernia? Protrusion of organs into posterior wall pockets. They doesn't come to outside. They inclinate it into the posterior wall pockets and can be pressed, can be strangulated. Can be strangulated. They can be pressed, they can be strangulated inside of the space. And again, let's count these 3 spaces. Right, please, subdiaphragmatical space. Subdiaphragmatical space. Subdiaphragmatical space. And we need attention into the picture. Now, attract your attention into all these blue space, which is shown in the picture. Yeah? What is it? Upper compartment with all removed organs. That's from upwards, you see the diaphragm. Subdiaphragmatical space means, attention to me guys, everybody, by falciform ligament of the liver, divided into two portions, right subdiaphragmatical and left subdiaphragmatical. Is it understandable for you? Maybe much more better, you can recognize it in this picture. Do you see upwards the diaphragm? Do you see downwards the falciform ligament? There's a whole subdiaphragm. Now imagine that my roof, it is the diaphragm. My floor, it is organs of the peritoneal cavity, mainly liver, but not only. And immediately mid-side, approximately by level of the midline, you have sagittally located ligament, which is called falciform. It is divided whole this subdiaphragmatical space into two portions, right subdiaphragmatical and left. Now right please, this subdiaphragmatical space by falciform ligament split it into right subdiaphragmatical and left subdiaphragmatical. Right subdiaphragmatical space we can call in another way. We call it right hepatic bursa. Let's say right subdiaphragmatical space or right hepatic bursa. Make attention again in the picture. Can I say the same for left subdiaphragmatical space? Can I call it also left hepatic bursa? Just tell me why. Why? Why right subdiaphragmatical space I can immediately call a right hepatic bursa, but left one no? Because in left side no liver. Look in the falciform ligament. Do you see this white structure? Can I say that left to it we don't have liver? We do or we don't have? We have or no? Friends, speak. Huh? We have? That's why I cannot call left subdiaphragmatical space left hepatic bursa. Because not only liver you have. Look to me. If you look to the right side, completely behind of all right portion of diaphragm, you have right lobe of liver. That's why they equal by its size, upper and lower wall of this space. But look to the left side, partly below diaphragm, I have liver, but only partly. In the most left part of this space, below diaphragm, I don't have liver. That's why it will be stupid if I will call whole this left subdiaphragmatical space left hepatic bursa. Instead of it, right please, left subdiaphragmatical space, split it into three portions. Make attention in the picture. Part of this space, the most right part, which is corresponded with the left lobe of the liver, we call left hepatic bursa. Part of the space which is located in the liver level of the stomach, we call pregastric bursa. Because if from diaphragm you will descend it to down, you will be in front of stomach. And finally, the last part of this space, which is located in the level of the spleen, we call the closed sac of the spleen, because spleen is covered by several ligaments. In Latin we say saccus cecus lienalis, closed sac of spleen. That's what the matter here. Again, I tell you, problem is connected with structures which is positioned below the left part of the diaphragm. Left part of diaphragm doesn't completely occupy by the liver. And from right to left, it is split into three portions. Look, portion 1, portion 2, and portion 3. This is a left hepatic bursa, this is pregastric bursa, and this is the closed sac of the spleen. It will be very clever to not understand after this my explanation what I say. Who is the most clever? Guys, don't be afraid. Yeah, if you have the problem, say me. If somebody don't understand it, I will not call you the most clever. Just tell me, please, I will explain it once again. Do you understand me? Can you repeat it, please, what we have in the left subdiaphragmatical space?
We have the liver, then the stomach and the spleen, three or
Why I cannot call it just the left hepatic bursa?
because the three organs together.
Super. Thank you very much. That's I remember it forever. This is very important. Once again, all subdiaphragmatical space, we divide it into two parts. Right and left. Right one, it is common space. That's why we call it bursa hepatica dextra. Left one, it's not common. It is divided into two. Friends, I'm very happy, and let's start from the right side. Right, please. Right subdiaphragmatical space or right hepatic bursa. Borders. Now imagine, friends, that I'm inside of this space. Above me, I have diaphragm. Below me, I have diaphragmatical surface of the liver. Yes or no?
Yes.
Super. Does I speak? Behind of me, I have the coronal ligament of the liver, which is connecting me with the diaphragm, together with right triangular. Yeah. Left to me, I have falciform ligament. Right to me, I don't have any border, and I am communicating with infracolic compartment of the peritoneal cavity. Look in the picture, please. Do you see any border here? Liquid can simply descend it from right side to down. And it will be communicated, by the way, meaning the tension to me, to this channel. Do you see this channel, which is between wall and ascending colon? We call it the right abdominal channel. Who can repeat it me? All borders now, after this explanation. Who will repeat it without my help? I will put 10. Super, stand up. But no mistakes. Right hepatic bursa.
So superiorly you have diaphragm, inferiorly is subdiaphragmatic surface of the liver.
Which surface?
Diaphragm is
No any noise.
Then medial you have or left.
Don't call medially. Call it right or left.
Left you will have falciform ligament, right you will have coronary. Right it will be a free space which will continue to inferior.
No borders.
And posteriorly around coronary.
Your name and group.
302
302.
Sorry.
Why 302? Today I have 303, 4, 5. Again my mistake. Dear head of the groups, I didn't take your register. I ask you, write only the names of absent people. Some give me, yeah? Remind me after to put, sorry friend, look, 304, 5, and 6. Sorry. Is it understandable for you? That's a right or remember. Once again, right subdiaphragmatical space upwards, diaphragm, downwards, diaphragmatical surface of right lobe. Left falciform ligament, right no borders. Back side, it is the coronal ligament of the liver together with right triangular one. I think it's not hard. Super. Now right, please. Left subdiaphragmatical space and portion 1, which we call left hepatic bursa. By the way, again the chance to achieve the 10. Who can stand up and without my help to describe the borders of the left hepatic bursa? Stand up, please.
On the right side, we have the falciform ligament. On the left side, we have the lesser curvature of the stomach.
I give you a chance to 1 minute think and answer. Okay, mention the borders which you can recognize before speak about left one.
On superior we have the diaphragmatic.
We have what we have. If it is subdiaphragmatical space, what is up to me? Diaphragm. Inferiorly, sit down, friend. Why you are stoned? It's so simple. Look, upwards diaphragm, downwards diaphragmatical surface of left lobe. She is right. In right side, it is falciform ligament. Back side, the same coronal ligament, now but left triangular one. But now the question, what is left? Super answer. Look, he's proved me that he needs this 10. I told you before that left subdiaphragmatical space, split it into 3 compartments and they communicated to each other. That's why left border is absent. And it is communicated with pregastric space. Is it understandable for you? This is very important. Right or remember, once again, bursa hepatica sinistra, upwards diaphragm, downwards diaphragmatical surface of the left lobe. Right border falciform ligament, left border absent, and it is communicated with second part of left subdiaphragmatical space, which is called pregastric bursa. Posteriorly, it is the same coronal ligament, but now left triangular, not the right one. Friends, I think it is not hard. Do you understand, or is need to be repeated once again? You, friend. Do you understand? You are here. This is the lecture of top anatomy. Don't be confused. Do you understand or no? Or you sleep? About what I speak, generally? What about I speak? Tell me, please. You don't understand it. You're here. Are you sure that you're here? Touch yourself, please. Borders of what? Huh? Left hepatic what? Bursa. Left hepatic bursa. Now you are inside of this bursa. Do you see this bursa or no? Where is it? Where is it? Now look. Is it left hepatic? No, don't speak. Is it left hepatic bursa?
Below the
1 minute. Is it left hepatic bursa? Is it left hepatic bursa? What the borders of it? From up.
diaphragm,
From down.
the spleen.
This is spleen. Oh, super answer. Super answer. Hurry up, my time has come to think. What is it, friend? Sorry? Which part of liver is it? Friend, that is not funny. That is left lobe of your liver. All food. All food. That's why again I say, especially for you, look to me. If I'm inside of this space, above me I have diaphragm. My floor will be diaphragmatical surface of left lobe of liver. Right to me, the window will be falciform ligament. Left to me, I will not have any border. I will communicate it with our friend. It is the next part, pregastric space. Finally, behind of me, I will have the coronal ligament of the liver, which is fix me to the diaphragm. That is not so hard. Now right, please. Second part, it is the pregastric bursa. Pregastric bursa. Right, please. Superiorly, it is presented by 2 structures. I will close this slide. Who will answer me? What will be superior border of this space? If it is pregastric space, what will be superior border of it? Who will answer? I will put 10. Especially today, I can promise for you everything because I don't have your register. Please.
The diaphragm and the left lobe of the liver.
But which part?
Inferior part of the left lobe of the liver.
Visceral surface, of course. Now look please to me. If I put my finger in the anterior wall, great answer, thank you very much, in the stomach and push my finger to up, from right parts of the stomach, I will become to visceral surface of left lobe. From left parts of stomach, immediately to the diaphragm. Let's say right, please. Upper border, presented by two structures. Visceral surface of left lobe of the liver, and it is the left part of the diaphragm. Now look to the picture. What will be inferior border of our pregastric bursa? What will be inferior border of pregastric bursa? Huh? Sorry? Lesser curvature. Lesser curvature can make the border. What is general border between upper and lower compartment of the transverse colon and mesocolon? Thank you very much. That's all right, please. Inferiorly, we have transverse colon and mesocolon. Now look again in the picture. Tell me, please, what is the posterior border of this space, pregastric space? Huh? It is space which is in front of stomach. What is posterior wall of it? Anterior wall of stomach and look in the picture. And lesser mental, yes, and lesser mental. If something located in front of stomach, posterior wall will be, it is the anterior wall of stomach, and the lesser mental. You understand it? That's all right, please. Posteriorly, it is anterior wall of the stomach and lesser mental. Of course, anteriorly, I will have anterior abdominal wall. To the right side, 1 minute, look to me. What is the right border of the pregastric space? You see falciform ligament. What is it? Discontinuation. Because falciform is finishing the round ligament. Super answer. This is round ligament of the liver. That's a right, please. In the right side, it will be bordered by two ligaments. It is falciform one and its continuation, which we call round ligament of the liver. Round ligament of the liver. And finally, guys, what will be the left border? No border. Saccus, cecus, leonalis. In the left side, it is communicated with saccus, cecus, leonalis. Is it understandable for you? Let's say this is very important. Remember, please. Now, right, please. Last space, it is saccus, cecus, leonalis. Look to me and let's understand. Where is it? I am the spleen. Now look, I will be the curved structure. My visceral surface look to the greater curvature of the stomach. I locate it in the level of the upper part of the greater curvature of the stomach. And in front of me, I will have two ligaments. It is gastrosplenic, which is located anteriorly, and it is the pancreatosplenic, which is located posteriorly. They forms the sac. Look, my belly, it is the hilum of the spleen. It is enclosed by these two ligaments, gastrosplenic and pancreatosplenic. One comes from the greater curvature of stomach to my belly. Second, from backside, come from pancreas. Why pancreatic ligament is located backwards? Why? Why gastric ligament located anteriorly, pancreatic ligament posteriorly? Why? Where is located your pancreas? Where is located your pancreas? Retroperitoneal space. Retroperitoneal space. That's why it is very logical that stomach ligament will be more anterior than the pancreatic ligament. Where is this sac? Now look to my borders. From left, it is hilum of the spleen. From anteriorly, it is the gastrosplenic ligament. From posteriorly, pancreatosplenic ligament. To the right side, it is open and it is connected with pregastric space, which we mentioned before. write the name of absent persons and give it to them.